Hello, and welcome back to the Healthcare Executive Insights podcast. My name is Elliot Sloan with the Macallan Group. Today, we are very excited to welcome our guest, Miss Allyson Augusta Shrikhande, who is the co-founder and chief medical officer at Pelvic Rehabilitation Medicine. Allyson, thank you so much for taking time to chat with us today.
Thank you, Elliot. Thanks for having me. Excited to be here.
Tell us a little bit about your professional background, and then we'll talk about your medical group.
Sure. So I am a physical medicine and rehabilitation doctor, otherwise known as PM&R or rehab. And I focus on the pelvis. So we are really pelvic rehab doctors. We treat anything from the belly button to the mid-thigh that in terms of pain or discomfort or issues with bowel bladder intercourse. It's the pelvic floor sling. And
Sure.
my background, I did my medical school in Ireland at the Royal College of Surgeons. And then I did my internship in surgery at Harvard Medical School, Beth Israel Deaconess Hospital. And then I completed my physical medicine and rehab residency at NYU Langone Medical Center. After graduating, I went to Cornell and was an attending there and helped to start the outpatient musculoskeletal pelvic health clinic there.
Wow.
And then from there, I went to private practice in New York City prior to co-founding Pelvic Rehabilitation Medicine, PRM, with my husband and co-founder, Dr. Allyson Shrikhande.
Wow. It sounds like you have had some of the most elite training and experiences out there for medical training.
Yeah, no, I've been lucky enough to be exposed to amazing mentors and teachers throughout my career. And it really is a blessing and has helped a lot.
And correct me if I'm wrong, I believe that this specialty of PM&R doctors is really about drilling down on complicated conditions and finding a diagnostic when it can be challenging to find a diagnostic. Is that correct?
That's exactly right, Elliot. I'd say two things that really for the PM&R training and physician. One would be we pride ourselves on what we call root cause analysis. So we really don't own one organ system, right? So we really are able to look at the body and see the interconnectedness between the different organ systems with each other, as well as with the peripheral nervous system, central nervous system. So it's interesting, but you're right. Because of that, I think root cause analysis and getting to the primary generators or pain generators in our world of pelvic pain comes a little easier to us because that's how we're trained from day one. And then also the second thing is something called, in the world of rehab, we exist because of neuroplasticity.
Sure.
And really that's just a fancy term, meaning your nervous system can change, right? The pendulum can swing in different directions. Originally our field was started post a lot of stroke rehab. So someone had a stroke, they're not able to move their right arm at first, right? However, because of that concept of neuroplasticity, the rehab world was formed, and we were able to, for many patients, get them functioning back and moving their right arm again. So conceptually at PRM, I really just applied those concepts to pelvic pain and pelvic floor muscle dysfunction, that neuroplasticity concept for treating our patients.
You must have a knack for being a detective, so to speak, and really liking to go the extra mile to lift up every rock and see what's underneath it.
Definitely. Yes. Yes.
Tell me a little bit more about Pelvic Rehabilitation Medicine and who you guys serve and where your practices are located.
Yeah, so we at Pelvic Rehabilitation Medicine, or PRM, we serve patients with chronic pelvic pain and pelvic floor muscle dysfunction. The majority of our patients are women, but we do see men as well. It's about 75% women, 25% men. We are a national healthcare company located from New York City to LA, but we're in New York City, New Jersey, Long Island. We're in Washington, D.C. area. We're in Bethesda, Maryland, and we're opening in a couple weeks in Falls Church, Virginia.
Wow.
And we're also in Miami, Florida, as well as West Palm Beach, Florida, Houston, Texas, Dallas, Texas. We're in Atlanta, Georgia,
Wow.
Detroit, Michigan, as well as Chicago, Illinois. And then our West Coast now is LA. So we're
Very
continuing to
impressive.
grow.
Congratulations. That's a huge operation.
Yeah, thank you. It's exciting. It's been really exciting and to see, the need and being able to bring the care to our patients nationally that's needed.
Yeah, I believe that there's a lot of people that need your help and your services and your expertise. Tell me about the fact that pelvic pain can be overlooked, I've heard, where patients may have conditions that are hard to identify what's the cause, and they're dealing with a lot of pain, and they're kind of running up against the wall of what's going on here.
Yeah, definitely. Particularly chronic pelvic pain. And the word chronic just means the symptoms, but going on for greater than 6 months. So that's really what that definition is. And why? Because really two things. In the world of chronic pelvic pain, at PRM, we really specialize in the nerves and the muscles of the pelvis. When pelvic pain's been going on for more than 6 months, the nerves are very inflamed and the muscles there are in spasm. That is what happens. And that is a clinical diagnosis. So that would not show up on the classic workup for a patient, such as imaging, ultrasounds, MRIs, blood work. So that is why it is often missed, because it's a clinical diagnosis, and really you have to know how to do an internal exam, which again is and evaluate the muscles and nerves, which is not that common in the healthcare profession to really be trained and know how to do that. And then also within the realm of chronic pelvic pain, endometriosis is 1 in 9 women, right? Extremely prevalent disease process. And our patients are often not diagnosed and ignored by the healthcare system because, again, another issue where endo does not have a diagnostic. The only way to diagnose it, technically, the gold standard is a surgery. So you'd have to go in, have a surgery, and then take pathology and the pathology report. So you can imagine the delay with the diagnosis for endometriosis. The average is 7 to 8 years before
Wow.
any of our patients, from when they first go to a healthcare provider complaining of their symptoms to getting an actual diagnosis. So those are really the two main reasons, is we're really dealing with issues that I think in the healthcare system, we don't have a quick diagnostic for either of those, the nerve and muscle issues and the endometriosis.
Wow, it sounds extremely challenging to really tackle, but it sounds like you're offering non-operative and operative solutions for this condition.
That's exactly right, Elliot. At PRM, we really believe in a comprehensive approach to endometriosis. So endometriosis, the definition of what it is endometrial-like cells are found outside of the uterus. So the lining of the uterus, those cells that are similar to that are found outside of the uterus. That's really the definition. And what happens with those cells, they get inflamed. So it's an inflammatory process, and then they heal with scarring. So it's constant inflammation, scarring, repetitively throughout a patient's life. So it is an estrogen-dependent disease process. And I mean, conceptually, it's a systemic inflammatory disease process, right? So it's really not just located in the pelvis. So that's why it is very important to have a comprehensive approach here. And when I say comprehensive, we have our core model, which really is a office-based procedural approach, non-operative, of course, really focused at treating that inflammatory process in the pelvis, which we call neurogenic inflammation. So reversing that inflammatory process and reversing the concomitant spastic pelvic floor musculature that only makes the inflammatory process worse. So that is what our kind of core model would be, and that non-operative ultrasound guided office-based procedural direct treatment to the pelvic nerves and muscles. But then we also have integrative nutrition in-house and behavioral health in-house to help with the downregulation of that central nervous system, because when patients do have those pain symptoms for quite some time, their central nervous system also gets upregulated.
Sure.
And then we also do have surgeons scattered throughout the country, because we do try to get patients as early as we can, but if we get them later, their endometriosis can be at a later stage. Right. And so then surgery would be, their option there. And then we work together with the surgeon. Sometimes we'll treat before the surgery in hopes that the patient's going to bounce back quicker after surgery and use less or no opioids post-op if we do that, because sometimes we'll treat after if there's residual neurogenic inflammatory issues, which is very common, and residual muscular issues and central sensitization. So we all work together. It's that
Sure.
comprehensive approach to treat the patient.
I think that's the biggest problem in our healthcare space is the non-holistic approach to treating patients and looking at all systems and how they all work together. Treating one piece at a time doesn't always make the best results for the patient. I'm curious, how many of these patients that you're treating are able to get pain relief and never have to go into a procedure?
A procedure, you mean a surgery, or?
Yeah, correct.
So yeah, that's a great question. So we are very outcome forward, and we're collecting a lot of outcome data. So 80% of our patients show a statistically significant decrease in their VAS, their pain score.
Wow.
And on average, it's a 50% decrease in your pain score, and anywhere from 6 to 8 weeks after treatment.
That's amazing.
We are showing that we are keeping our patients, once they meet us, we're keeping them out of the emergency room, which ultimately leads to less hospital admissions for our patients, right? It's a 97% decrease in ER visits.
Wow.
So essentially, we're really keeping them out of the ER, which when they go to the ER, the workup again would be normal. It's frustrating for them. They're given opioids, which don't help. If anything, they make everything worse, really, for our patients. So I think that is a huge, huge win. And we're showing that we are keeping our patients working, right? We're looking at absenteeism and presenteeism data. Presenteeism means being able to focus, right, where you're at work. And the data is astounding. I mean, we're collecting it every day, so it's constantly, the numbers are constantly, the end's getting bigger and bigger. But
Sure.
really, we're showing that, we're able to keep our patients not only going to work, but being present at work. And then we're keeping them functioning. So we're looking at something called functional pelvic pain scale, where we're saying when patients, after our treatment, they're able to sleep, they're able to exercise, they're able to have intercourse where they wouldn't be able to have intercourse before, and their bladder and bowel functions are also much improved.
Sure.
So yeah, that's all kind of the outcomes: function, quality of life, as well as pain. And then we are looking at 1-year data for patients who underwent our non-operative treatment protocol and versus patients who did not 1 year later, right? So we have a control group now. And it's astounding to see that, what the patients who were treated have shown to have a statistically significant decrease in the number of surgeries required versus patients who didn't undergo the treatment.
Wow.
As well as decrease in overall just procedures, right? Diagnostic and therapeutic. So because they were getting better, they stopped searching for answers, right? So the decrease in cystoscopies, endoscopies, colonoscopies, procedures that were diagnostic decreased significantly because they were feeling better, so they stopped searching for the answer.
Wow.
And then also, just decreasing overall treatments required. So it's been amazing to see for the patient as well as the healthcare system, decreasing the burden.
I was going to say, you're bringing down costs across the board from diagnostics to actual procedures. And from what I understand is, even if you have an endo procedure, it's not a one and done. It could come back and you need multiple. Is that correct?
That's exactly right, Elliot. I mean, endometriosis, which does represent about 70 to 75% of our female patient population, is a chronic disease process, right? So conceptually, the data says post-operatively, 50% of patients require a second surgery
Wow.
within 5 years. So it is, and conceptually at PRM, what we're trying to do is decrease the total number of surgeries our poor patients have to undergo, right? So essentially, that is really our mission and our goal, to decrease the total number, to work with high-level surgeons, but really not have them running into surgery every year.
Sure, you're going to try to keep them away from the surgeons as long as they can until that's their right option.
Exactly, exactly. And endometriosis itself grows or proliferates in inflammation, right? So something called pro-inflammatory cytokines that can hang around in the pelvis and the peritoneum. When they are present, endometriosis grows even more. So it's estrogen dependent, but then it also proliferates in inflammation. So conceptually, when we are doing a direct treatment, going in there and increasing blood flow, reversing that neurogenic inflammatory process in the pelvis, it will help slow down the progression of endo continuously spreading and growing.
Sure. And how does this impact fertility? I know that's a big concern as a society, how the data shows us that it is becoming more and more challenging every year for women and men to have children.
Yes, yes. I mean, fertility is extremely common, and with endometriosis, it presents with pain and or fertility, sometimes often both, right? So there is quite a bit of a crossover. And what's the connection with endometriosis and fertility? Multiple reasons. One is more mechanical, because as I had explained prior, with endometriosis, you get these plaques that get inflamed and scarring, right? Inflamed and healing, which is like scarring or adhesions, we call them.
Sure.
So they can mechanically block the fallopian tubes, right? So it's a mechanical problem with endo.
Sure.
And then in addition, the effects of endometriosis on the endocrine system, something called the HPA axis, hypothalamic pituitary axis. So that also causes fertility in endometriosis patients. And then the third reason really is coming back to what we had discussed, is that neuroinflammatory process and that immune neuroinflammatory issue in the pelvis that we had talked about can be challenging for pregnancy to hold, right? When things are inflamed, the implantation.
How much of this is related to what you consume dietarily speaking, with all this inflammation, right? It feels like for a long time, people have been eating things that are really causing gut issues, pelvic issues, inflammatory issues. Do you spend a lot of time focusing on adjusting the diets for your patients?
We do. I mean, the data, we don't have strong data on it, to be honest with you, on the direct effect of diet and nutrition and lifestyle on endometriosis specifically.
Got it.
However, we do. I mean, conceptually, we have a fantastic integrative nutrition course. We actually have two of them, Jen Navon and Monique Bogny. Really, one is for endometriosis only, and one is really just talking about gut health overall.
Sure.
But we do really work closely with our patients, either one-on-one or in these group courses, to review detoxing, right? Detoxing really your diet and your everything, like your body and your cabinets, this exposure to chemicals overall,
Yeah.
as well as, a diet that is classically anti-inflammatory. Cutting out, dairy and gluten is pretty common.
Sure.
And then going through what to eat, making it as fun as possible. And you do tailor it to the patient. But yes, I mean, classically, when we see patients, we do our standard treatment, our direct treatment, to get them better, right? Because they're coming in, they're uncomfortable. Whether it's even just pain around intercourse or bladder or bowel or constant lower abdominal pain, whatever it would be, but they're uncomfortable. So we get them more comfortable. We get them their pain down. We get them functioning, right? And then at that point is when we really take more time to talk about lifestyle, because we think and we believe at PRM it's a strong factor for flares, flares or relapse, right? So once we don't just say take this diet when they're not feeling well, we really do our treatment to get them better. But once they're in a better place, that's when, I think they can really listen and say, if you change this, then it will help. It will help long term. So we talk about nutrition,
Sure.
exercise, right? Exercise overall, so many things, right? Benefits for the oxidative stress there and the brain and the pelvis. And then we also talk a lot about breathing. So like mindfulness, meditation, muscle relaxation, and the effects on the deep breathing with the vagus nerve, which again goes through the central nervous system connecting to the pelvic floor. So we have a lot of lifestyle, but quite often we do it once they're in a bit more comfortable place.
Yeah, you start with the short-term strategy and then
Yeah,
you deploy the long-term.
exactly. Exactly.
Makes a lot of
Mhm.
sense. I love what you guys are doing, and it sounds like you're changing a lot of lives and keeping people away from surgery as much as you can, unless that's their best option. You're bringing down the cost for the whole healthcare system. You're bringing down the cost for the payers. Um, why does it feel like there's not enough groups like yours out there?
Yeah, Elliot, I know. I think it's a newer field, right? For it's a newer field. Classically, I was a patient. I had my own issues, which is how I kind of got into this. And classically, I mean, GYNs were really looking at this, but they have a lot on their plate, right? There's a lot they have to look at, including ruling out cancer, delivering babies, a lot going on.
Sure.
And I think that PM&R docs or even family practice doctors hadn't really taken a look at this field before. So,
Mm-hmm.
but I think we are great people to quarterback it, nurse
Mm-hmm.
practitioners as well. So it's a newer field that's being created, and really I just wanted a better way, because classically before, what we were doing, it was kind of transvaginal blind, and or if it was guided, it was under an X-ray C-arm, which has radiation, and young women don't really love radiating their ovaries, right? So they
Sure.
prefer ultrasound. And then also the location was more risky, so it's in a location that's less risky and more comfortable. So it was
Sure.
kind of for myself, that's what had happened. So something that was more comfortable, could go on with your day, didn't need anesthesia, and more efficacious. So that's really where it came about, and it's a newer field. So I think we're growing. I'm just always honored when another either nurse practitioner, doctor wants to join us and it gets excited and gets behind the mission and just really becomes passionate about this, I think, amazing new field that's needed and growing.
Absolutely. I think you guys are providing access that is just not out there, unfortunately, like it should be. You're scaling quickly, and it sounds like you're in a lot of major cities around the country and will continue growing at an awesome pace. I'll leave you with this question. What are you most excited about for the next few years? What is the game plan? 2, 3 years. What's most exciting for you at PRM?
So at PRM, I'm really excited to continue to grow and across the country with new sites, new de novo sites, as well as continue to provide access to care, right? To continue to work with insurances and the healthcare system, provide access to care for patients who really need it, as well as save our healthcare system money.
Sure. One more follow-up question is, do you see the diagnostics getting any um, improving to get people without having to have a surgery to know this is what they have with endometriosis?
With endometriosis, yes, the diagnostic for endometriosis, I'm hopeful will come down the pathway fairly soon. I know there's several kind of things out there.
Sure.
We at PRM and I specifically have worked closely with something called the ROSE trial, Research Outsmarts Endometriosis. So have been involved with collecting the data, and what it is analyzing menstrual effluent for biomarkers that may show endometriosis versus not. So that is out there. There's multiple things I think coming down the pipeline, and I am hopeful that one day, we'll have a diagnostic for endometriosis that is not surgery.
And a solution that does not require multiple surgeries.
Exactly. So yes, that's exactly right.
Well, Allyson, thank you so much for your time today. It's been a real pleasure chatting with you, and continue scaling and providing access to this unbelievable care you're delivering.
Thank you, Elliot. Thanks so much.